to maintain the successful program in the country. What I have involved in the last 10 years for the HIV, I found that the prevalence of HIV drug resistance in Vietnam is quite low compared to other countries in the world. So we have a chance to conduct a national surveillance of HIV drug resistance in the country, and it always show very consistent data about the prevalence of HIV drug resistance, less than 5%. It show and support for the successful ART program in the country. However, what we facing now, even we can provide ART for the people at various stages of HIV infection, we can bring people to the program, but we still see a lot of people with HIV, they die. So one of the reasons we recognize is related to the advanced HIV disease. And in 2017, WHO released a guideline which mentioned an approach to the management of HIV, of advanced HIV diseases. In Vietnam, at the same time, we have a quite big study looking at the advanced HIV through the cryptococcal antigen screening in the country. And we found that between 2015 and 2017, around 40% of people with HIV was enrolled for the ART program with CD4 count less than 100. So with this number, it shows that many people in Vietnam, they still access to the healthcare system at the late stage of the disease. And also, you can see in the table, we listed the most common cause of death among the people with severe advanced HIV disease. That was a story 10 years ago. So we can see the high prevalence of tuberculosis and also other opportunistic infection. After 2017, I had a chance to conduct a survey of advanced HIV in Vietnam between 2022 and 2023 during the COVID-19. So we're looking at the infrastructure, availabilities of diagnostic, the drug, and also we want to looking at the prevalence of the opportunistic infection among the people with advanced HIV disease. What we found in the survey, we still see a lot of people with advanced HIV. However, the access to the CD4 count testing was very limited. You can see in my survey, around a half of people with advanced HIV, which diagnosis with the clinically diagnosis, thus have no access to CD4 count testing. So that is the problem because during this period, we don't have a reagent because a lot of the donor, they cut down the budgets for Vietnam, even for CD4 count testing. And also what we found in our population that among the people with advanced HIV disease, you can see their mean age is just around 35. So that means they're still young. However, they come to the clinic with advanced HIV disease. That is the point we want to improve and strengthening the capacity for management of advanced HIV in the country. And when we have a question about what is the most common diagnosis of advanced HIV diseases among the people come to the clinic, we found that the pattern of etiology almost unchanged since the last study. We still see a lot of people with tuberculosis and other opportunistic infection, including the cryptococcosis, tharomycosis, and other diseases. But what is the gap in Vietnam in management of HIV? That because we like the staff. Very few doctors now working on HIV to take care of a lot of people because in Vietnam, we still treat and provide ART at the clinic, and we see not much doctor and nurses involved to the process. And also we can see that the capacities of diagnosis is very, very low. I could tell you that almost zero for the fungal diseases, almost zero for mycobacterial infection. So that is the point we need to fill the gap in Vietnam. So the picture of lacking the CD4 count testing, lacking the diagnostic is a problem for Vietnam right now. And also you can see here the capacity for diagnosis of the advanced HIV disease for fungal diseases, including the cryptococcosis, histoplasmosis, and tharomycosis is very, very low. But the question is that, are they exist in Vietnam? I mean, the opportunistic infection. I don't mention a lot about other fungal diseases like candidiasis, PCP, or toxoplasmosis because they can do a kind of clinical diagnosis, but just look at the study to see how the treatment and the gap the research need to fulfill for the management of advanced HIV disease. Those are the most common invasive fungal diseases for the HIV people. You can see the red one that we have no data, we have no access to the services. And in a study that I work with Professor Thuy Lê from Duke University, we try to provide intensive screening for advanced HIV among Vietnamese population. So those data has not been published yet. We hope that we will publish this year or early next year. This is a study we conduct in two biggest hospital for management of advanced HIV disease is a National Hospital for Tropical Diseases and Hospital for Tropical Diseases in Ho Chi Minh City. This is very first data. You can see here, we try to provide all diagnostic we have for screening advanced HIV disease for fungal diseases. And you can see here, we see quite high prevalence of tharomycosis, and tuberculosis. So for tuberculosis, when we provide the intensified screening, we can detect nearly 30% of people with tuberculosis. So it confirms TB is still be the highest burden of disease among people with advanced HIV. But besides that, we reported the high prevalence of tharomycosis, which is invasive fungal diseases very endemic for Vietnamese and Southeast Asia region. And besides that, this is the first study we report the cases with histoplasmosis. Actually, we don't have much data on histoplasmosis in Vietnam so far, but through our study, you can see we have a 3%, around 3% of people with advanced HIV can have a histoplasmosis and other opportunistic infection you can see on the slide. And similarly, we also found the patient, beside the high burdens of tuberculosis, we also see the people with mycobacterium infection. NTB is also very interesting infection. We need to have more research to see how we can distinguish with TB and what is the burden of disease among our population. So this is the maybe the last results I want to show you about the mortality. We have a very good ART program. However, how we can save the people's life, that is the point. So it's not a matter of the coverage of ART, but it's a matter of early diagnosis and provide the treatment for the people with advanced HIV disease. And as shown in the slide, the mortality of TM is around 12%, and TM mortality is higher with the 34%. TB is very high, as you can see, up to 70%, and very high mortality caused by cryptococcosis, up to 43%. So in Vietnam, we aim to revise the national guideline to update the ambition regimen, which is a new regimen suggested for, recommended by WHO for the cryptococcal meningitis. However, the lack of ambosome and also flucytosine is another gap we need to fill. In conclusion, as I show in my study, so it's very small proportion of the picture of the HIV disease in Vietnam, but you can see a large proportion of people with advanced HIV presenting to the clinic at the late stage of the disease. We like the human staff. We don't have enough the diagnostic to make a diagnosis of the fungal diseases, TB, NTM, and other opportunistic infection. And I think that the research that we would need now that we need to increase access to CD4 count testing, and also we need to research on an intensified approach for screening, management, and also prevention of fungal and bacterial infection for Vietnamese population. Thank you very much.
Okay, thank you very much. So the next speaker is Sokea Hnkh. She's a project manager of the Fungicam Anrs 0465 project at the Medical Biology Laboratory in Institut Pasteur in Phnom Penh within the Bacteriology and Antibiotic Resistance Research Group.
Good morning, everyone. My name is Rasmay. I'm from Pasteur Institute of Cambodia. Today, on behalf of my team, I would like to present the Fungicam project, which is a study on the prevalence of two invasive fungal infections, histoplasmosis and thalassemomycosis, in severe immunocompromised HIV patients in Cambodia. Invasive fungal infections are the opportunistic and life-threatening disease that mainly affect people living with advanced HIV. This infection is responsible for over 1.5 million deaths annually worldwide. Histoplasma capsulotum and Saccharomyces magnifica are the two major invasive fungal infection pathogens in the advanced HIV patient. Histoplasmosis, which caused by Histoplasma capsulotum, are typically present with disseminated disease and also the symptoms such as fever, weight loss, hepatosplenomegaly, and skin lesion. Thalassemomycosis, which caused by Saccharomyces magnifica, is also present with fever, skin lesion, anemia, and weight loss. Both infections are recognized by the WHO as the fungal priority fungal pathogen. Despite the significant burden of the invasive fungal infection, there are still major diagnostic gaps in Cambodia. First, there is limited awareness of this invasive fungal infection among the clinicians, and the clinical presentation of the infection is quite similar to the tuberculosis. Third, the availability of the reliable diagnostic test is still limited, and fourth, the epidemiological data in Cambodia is also limited. The conventional diagnostic methods like culture take a very long time, up to several weeks, and also require the biosafety level, which is BLS3 or BLS3 or 2. So this often lead to the delay or absence of the antifungal treatment, which lead to the severe illness or death. And recently, the antigenic and molecular methods have emerged as a promising tool for the rapid diagnosis of the invasive fungal infection. And this leads to the primary objective of our research study is to evaluate the prevalence of this invasive fungal infection among the people. Hello? Okay. So I will begin again with the objective. So this leads to the objective of our research study, which to evaluate the prevalence of invasive fungal infection among the people living with advanced HIV in Cambodia using rapid antigenic and molecular diagnostic tools. And also, To determine the proportion of co-infection between TB and the invasive fungal infection, and also to raise awareness and train the healthcare provider on this invasive fungal infection and the new diagnosis tool. And the third secondary objective is to establish the protocol by rapid diagnostic test and PCR for the detection of both fungal pathogens. So this study is a retrospective study that we work on the biobank sample from the people living with advanced HIV in the study. And this is the inclusion criteria of the participants from the study that they were newly diagnosed with HIV, no history of antiretroviral treatment, no TB treatment within the previous 5 years, and also no ongoing TB preventive therapy. For the sample size, we have 193 participants with available sample from the study biobank that is at the Institute Pasteur of Cambodia. For the laboratory testing, for the histoplasma capsulotom, for antigen detection, we use two methods, which is the lateral flow assay and the enzyme immunoassay. And then we confirm the positive antigen sample with the molecular assay. And for the Saccharomyces manifest, we perform only antigen detection assay using the lateral flow assay, and then we confirm with the molecular assay. So here for the result of the histoplasmosis, we found 9 samples with positive by LFA and also positive by EIA. Combining both antigen tests, LFA and EIA, we have 10 samples with positive histoplasma, and then we confirm with the RT-qPCR. We found 3 samples were positive among the 10. Among the bacteriologically confirmed TB of 11 people, we found only one patient that had a co-infection histoplasma and also TB, tuberculosis TB. And we observed that the sample with high antigen level of antigen by the EIA were PCR negative. However, for the sample that has low antigen level are PCR negative, and this demonstrates the positivity by PCR is correlated with the high antigen burden. So moving to the result of Saccharomyces, we found only 2 samples among the 193 samples were positive by Saccharomyces LFA, and then we confirmed with the RT-qPCR. Both samples were positive for Saccharomyces. And we don't find any patient that has both co-infection between Saccharomyces and TB. For our finding, the histoplasma antigen area, the prevalence by FFA is 4.7% and EIA 3.1%. Among the 10 samples that were positive, we found 2 samples that were positive with histoplasma LFA but has a negative EIA and RT-qPCR. However, this sample has positive by both LFA and RT-qPCR. So we suggest that these 2 samples are likely histoplasma growth reactivity rather than through co-infection between histoplasma and Saccharomyces. And regional report from our neighboring country, from Thailand, there are 129 cases, and Indonesia 29 cases. The difference suggests the underdiagnosis in the region without the routine antigen testing. And for the Saccharomyces case, this is the first time in Cambodia that we found Saccharomyces positive among the patients with advanced HIV in Cambodia, which correspond to 1% prevalence. Looking at the neighboring country, such as Vietnam, they have 6.4%, Thailand 3.9%. The difference of this prevalence may reflect the geographic variation, the difference in patient population, and also the diagnostic availability and screening strategy. There are also several limitations from our study. First, the long-term storage of biobank samples. Second, the potential cross-reactivity between the antigen detection assay. And third, no comparison with the culture or direct examination, which is the gold standard. And fourth, we have a small population of TB patients, which is only 11 patients. So here is the conclusion of our study. The prevalence of probable invasive fungal infection among advanced HIV patients in Cambodia. We observe histoplasma by LFA 4.7% and EIA 3.1%. For thyroid by LFA and PCR, we found 1%. And we conclude that invasive fungal infection contribute to the diagnostic complexity in high TB and HIV burden setting, and also the rapid antigen-based assay improve the early detection of the invasive fungal infection. So therefore, to integrate the antigen and molecular diagnostic strategy are essential for the accurate diagnostic and timely management. And from our study, we recommend the strengthening laboratory capacity by validate and implement the histoplasma and thyroid LFA as the point of care screening tool in TB and HIV clinic, and also establish the molecular confirmatory test at the reference laboratory, and also provide the training for the laboratory staff of the invasive fungal infection. And also, we recommend to integrate the antigen testing for the histoplasma and thyroid into the national HIV guideline for the advanced HIV patients in Cambodia. And for the prospective study is to conduct multi-center to determine the current prevalence and also identify the geographic hotspot for both pathogens. And as part of capacity building activity, which is one of the objectives of our FUNGICAM project, we conduct laboratory training workshop and also the clinical training workshop to strengthen the local capacity in the fungal diagnostic and also clinical management of the invasive fungal infection. And lastly, I would like to present to thank you all the member of the FUNGICAM team. That's all for my presentation. Thank you for your attention.
PrEP has become a key component of HIV prevention strategy worldwide. To share important findings from Vietnam, I would like to invite Professor Lê Vinh Giang from Hanoi Medical University, who will present research results on PrEP in Vietnam. Associated. No.
Vâng, em cảm ơn cô ạ. Good morning, everyone. Thank you. I would like to express my gratitude to Anrs coordinators, Dr. Didier Loria and Professor Phan Hương, for inviting me to provide an overview of the research that what we have conducted on our PrEP clients. And I'm especially pleased to be here this morning and attend the conference because this is an opportunity for me to see many of my friends again after such a long time, and also to meet new friends from Cambodia and from other countries as well. So 2 years ago, I also gave a similar presentation focusing on PrEP and some of the research that we have conducted at Hanoi Medical University. This morning, I would like to return to this topic again, but with new updates on what we have been able to achieve over the past 2 years. I focus largely on the results from our university work because although there are many other researchers doing research on PrEP in Vietnam, but I would like to focus on our own work because this is what I know best. Thank you. I would like to thank also Dr. Hao for Bu Timing Hao for actually helping me to prepare this presentation, and also a lot of the work involved here is result from her own work. So this is what I would like to talk about. One is the overview of our PrEP program, some of the research studies that we have been able to complete, doing both the secondary data analysis, but also new studies that build on the platform of our clinic. And then I would like to give a few suggestions on how we move forward in the future. Especially, I'm looking forward to be able to collaborate with our French colleagues on some of the ideas. So here's the history of the PrEP program at our hospital, at our clinic. We built the first PrEP program started in 2019, but we actually built this service on the long history of our research on MSM in Vietnam. We started in early 2010s with a sexual health promotion program focusing on health education and behavioral change. And then we conducted a very large study on HIV incidence before PrEP among MSM in Hanoi. And that study documented a 7 per 100% incident rate among MSM before PrEP. And that was the evidence to urge our government to start the PrEP program in Vietnam. And in 2019, we opened the first clinic, one of the first clinic in the country, and it was at the University Hospital. And in September 25, when the PEPFAR program ended, so the clinic that we opened in 2019 was supported by PEPFAR. But since the end of PEPFAR support for PrEP starting early this year, in September 25, we opened the first pay-for-service PrEP clinic, which is not far away from here. And so we separate the two clinics. One is focusing on research that are all fully funded by research. And the other clinic is that we provide the services for clients who come and pay for their own services. Okay. And here's the total number that we have up to this point. By the end of 25, cumulatively we have almost 7,000 clients receiving PrEP from two clinics that we are running. Right? And in addition to the PrEP, we also provide many other services as listed here in some of the numbers. And I'm very proud that now our PrEP clinic is not just only PrEP, but it's a one-stop shop model that when the clients come to our clinic, they receive the HIV testing, they receive STI testing and treatment, but also they get other services such as the mental health care, SUD, substance use disorder screening and interventions. But also they may, if they have other health issues, they could get services at our hospital, which is a general hospital. So now let me go to some of the results from the data from our research. So I'll describe first some secondary data analysis. Right. The first one is on the PrEP discontinuation, which is defined as a missing follow-up visit at least 30 days after the scheduled visit. And here you could see that we compare different groups in terms of the first PrEP discontinuation. The first group in the blue line is the event-driven PrEP. The second in the orange line is the daily prep. And the third one, which is the red, is the switcher, which means that they could switch between the two regimes. So the graph on the left-hand side shows that as you could see that by 6 months, almost 50% of our all of the 3 groups, 50% drop out had the first discontinuation after 6 months. And this is a major challenge for PrEP program in Vietnam. And I believe that it's not just Vietnam, but also many other parts of the region. And then comparing among the 3 groups, we see that the switcher actually they have a better retention in the program. And the other group, especially the event-driven group, has the much lower retention, and they started by the 12 months, for example, by the 6 months, for example, or they already less than 20% of the event-driven PrEP group had the first discontinuation, right? So this is a major challenge in terms of the adherence and persistence among our clients. And so thanks to the large number of clients in our program, we were able to document the incidence of HIV incidents among our clients. So here you could see that over the period of from 29 to 24, so this is 24, we had about 6,000 initiators, and we were able to document people with at least one follow-up visit, one follow-up HIV testing after the initiations. And in total, we had about 6,000, more than 6,000 person year of follow-up. And we documented 70 seroconversion. Then that translates into about a little more than 1 per 100 person year. So remember that before PrEP, it was 7 per 100 person year. And now even with PrEP, and especially given the discontinuation and the inadherence, the incidence still remain very high. And this is unacceptable, right? This is unacceptable in the age of biomedical intervention. So there's a lot of things that we need to work on in order to eradicate or let's say stop HIV, especially among MSM in Vietnam. And this is the challenge that we are faced with. And here's some of the, again, risk factor for HIV incidence. So the younger they are, the more high risk of HIV incidence. And also the discontinuation that I presented earlier, the single daily PrEP regimens, also risk factors for HIV, getting HIV, and also the people who had history of syphilis in the past and now not eligible for getting tested with syphilis in the PrEP program are also a risk factor for them. So people with previous history of STI is one of the risk factors for getting infected, seroconverted, even while in the PrEP program. So these are some of the key factors that we need to address in our PrEP program. And last but not least is the issue of when we look at the seroconverted cases, this is the number of people that we were able to obtain the sample from and tested for drug resistance. And there was 5 cases that we were able to identify the drug resistance among the PrEP seroconverted cases. And here's some of the mutations that we were able to detect in the oral PrEP populations. So here's also an issue that we need to monitor in our future PrEP program. And here's the, interestingly, we were able to document also the syphilis incidence and also the new syphilis cases. And when you look at this graph, the blue line is the new syphilis cases and the black is the syphilis incidence. So here's that, interestingly, in the first 6 months, in the first 12 months, the number of incident, the trend of incidents, but also the new cases seems to go downwards. All right, and that's also very interesting impacts of the PrEP program. As they enroll in the PrEP program, they get screened with for syphilis, and that's also help with the STI prevention as well. But then after the 12 months, it seems like the number of cases and the incidents starting to popping up, and this is a trend that we need to continue to follow over time. So let me go to this. So those are the data that based building on the program for the secondary data analysis. And now let me describe some of the new studies that we have recently completed or are ongoing, built on the platform of our clinic. So here's the first study by Dr. Paul Adamson from UCLA, and who was able to, among the more than 500 men attending our PrEP clinics, this is the prevalence of different STI. Here's the chlamydia trachomatis and the gonorrhea, right? So see that at the pharyngeal side, the highest is the gonorrhea, right? But in the rectal side, the highest is chlamydia, right? For the urethral, the highest is the gonorrhea. And interestingly, the people with the symptoms actually have higher positive result as people compared to people who reported no symptom. Among the more than 60 samples that we were able to culture, this is the result of antimicrobial resistance for the gonorrhea that we're able to detect in the study, and very high risk of microbial resistance with the azithromycins, and then cefixime and ceftriaxones. And Vietnam is on the highest, the country recorded highest AMR in terms of STI in the regions and also in the world. And this is something that I think very important area that we need to invest in the future. The next study that also conducted on the platform of our study is the focusing on doxy PrEP. And this afternoon you will hear more about this result. And I'm not going into detail about the doxy prophylaxis, either PEP or PrEP among MSM. And this is the most recent study which is ongoing, is that, substance use, especially alcohol use, is very prevalent in Vietnam and many other parts of Southeast Asia. So we would like to look at how reducing alcohol could help to improve PrEP adherence and PrEP persistence. And here's the clinical trial that funded by NIH with the intervention on reducing alcohol use in order to improve the PrEP persistence. So far, we have completed the recruitment of more than almost 600 participants got randomized into two arms. One arm receiving the intervention we call brief alcohol interventions, and the other arm is standard of care, just giving advice and educational materials. And we will hopefully in the next conference in 2 years, I'll be able to report on the result of this intervention. And we just started to launch we wanted the site to in the multi-site global study looking at the oral long-acting PrEP once a month. And this is study funded by MSD. I don't know any of the French PI here also have the site for this kind of long-acting PrEP. And we just started to enroll our first patient on March 6th. And here's comparing the investigative product, which is MK8527, as I mentioned, once a month oral, compared to the FTC TDF, which is daily PrEP, right? So hopefully this study will be completed in 2030. So 4 years from now, hopefully we'll be able to hear some of the result from this very I consider as very important product. Not instead of, which is a long injectable, very expensive for countries like Vietnam or Laos or Cambodia. So once a month oral may be a very good solution for us, right? So here's some of the suggestions for collaboration on PrEP program in Vietnam. We would definitely would like to continue evaluate effectiveness of long-acting PrEP products in Vietnam, in the context of Vietnam, but also compared to other countries in the regions. Of course, the implementation science, combining both clinical trials and social science study is very important. We would like to look at especially the issue of retention, but also the management of other health issues like STIs, mental health, substance use, alcohol use among our population. Digital health approach is one of the areas that we would like to develop further. And last but not least is the issue of resistance, both to bacterial STI resistance, but also to the viral resistance as well. There's a new PrEP product emerging. So thank you very much for your attention. And again, I really appreciate being able to present our ongoing work on PrEP and related issues in Vietnam. And I would like to acknowledge this is the grant support mostly from CDC and NIH for our continued work on this important area. Thank you.
Okay, so the last speaker of this session is Louis Sagaon-Tessier. He's an economist and public health research professor in IRD in France, the French National Research Institute for Sustainable Development. And now he's based in UHS in Phnom Penh at the University of Health Science.
Thank you very much. Good morning, almost afternoon, everyone. So I'm presenting this work on behalf of my colleagues of the University of Health Sciences, the HIV program in Cambodia, then Chad, and my colleagues in System Research Unit in France. So what a nice thing as appetizer, having social sciences about PrEP in Cambodia. So the work I'm presenting today concerns the QualiPrep Cambodia study funded by Anrs and being an assessment, qualitative assessment for PrEP acceptability and implementation in Cambodia among key populations. So in 2024, it was estimated that 76,000 people were living with HIV in Cambodia. Cambodia has made a significant progress in the HIV program with the targets 95, 95, 95, being currently in 2024, 92, 100, and a little bit more than 98%. It is an epidemic that is concentrated among key populations with a prevalence, overall prevalence of 0.5%. As you can see in the slides, there is still new infections in Cambodia, and in 2024, it was around 1,200 new infections, concerning mostly MSM, clients of entertainment workers, and partners of key populations. There were also transgender women represented in these new infections, and female and male entertainment workers. In this context, there was also a memory in the Cambodian authorities, populations, and the scientific community that was the interruption of a clinical trial in 2004 among sex workers that made PrEP being controversial and that highlighted the importance of balanced international collaborations in order to align cultural norms with research and give the place to local researchers for better understanding of the context. So in this epidemic and with this background about PrEP, it was very important to conduct studies to understand what happened about the acceptability and the implementation of PrEP that was going to start at the same time that this study has been conducted. Many research questions were raised concerning the context around HIVs and STIs, and especially, of course, about PrEP in terms of acceptability, the benefits, the drawbacks, how people wanted to use daily or event-driven PrEP, community-based, hospital-based, or what about the representations about injectable PrEP. And we wanted to have the overview of this acceptability, not only among populations, but in a comprehensive framework, including community-based organizations, healthcare workers, and policymakers. This study has been conducted with participants in 7 regions in Cambodia, and data started being collected in 2022 at the same time that the PrEP program started the rollout in Cambodia. We used the community approach with community-based organizations that were very, very important in the recruitment of key populations. We had 8 focus group discussions, 7 semi-structured individual interviews for a total of 88 participants in the study. As you can see here, we have a diversity in terms of key populations, community-based organizations, and healthcare workers. And what is important to see is that as it was, the study was conducted at the same time that the rollout was being done in Cambodia, we could have some participants that were already PrEP users at the time of the interviews. So, of course, we included the National AIDS Authority and the HIV program, and also the umbrella community-based organization, CANA. In terms of results, what we can see is that key populations had many factors perceived as risk factors for HIV, especially the use of drugs, the practice of chemsex, but also sexual practices that were less explored at that time. They considered that the access to information about preventive methods was very important, and that there was a broad way of information channels, mostly with community-based organizations through websites, friends, hospitals, doctors, and health centers. So overall, a very good way of communication, but some difficulties identified in some provinces. So in terms of the use of preventive methods, it depended on whether the partner was random or stable, and especially was asked in the use of condom and some adaptation of practices with partners. As you can see here, policymakers and community-based organizations and healthcare workers were aligned in terms of the populations to be targeted for PrEP, but the main community-based organization was only focusing on 2 populations that were transgender women and MSM under 30 years. We have found that there was low knowledge but high acceptability given various benefits identified by population and stakeholders, especially the possibility of screening for STIs among healthcare workers, but also the possibility of saving some money to be implemented in other areas of the HIV program. And for key populations, one of the main advantages was condom replacement. However, there was consensus in the idea, in the perception that PrEP would have a very important impact in the prevention for HIV. And one important thing that we have found is that the approval from authorities was very, very important for the creation of trust among population and among other stakeholders. In terms of structural barriers, on the side of the stakeholders were mostly in terms of the lack of demand creation, the difficulty of follow-up with the loss of follow-up, the cost of transportation for users, and the need of widespreading the services in Cambodia and the difficulties that this would imply in terms of logistics. On the side of the individual barriers, the 3 most important were that PrEP was not protecting towards STIs, the fear of side effects, and HIV-related stigma. As you can see in this slide, except transgender women, all key populations manifested their preference for daily PrEP because it was less complicated and allowed them to avoid the forgetfulness risk. For transgender women, on-demand PrEP was preferred because this allowed to reduce their fear of side effects, for example, in the interaction with the hormonal therapy that they perceived at that time. Concerning the perception of injectable PrEP, there were many advantages of this type of PrEP, especially avoiding the burden of pill intake, working faster, long-lasting, and with a reduced risk of non-adherence. And overall, policymakers were favorable for the implementation of this type of PrEP. Some barriers were identified for the hospital-based PrEP, mostly the lack of information, but also the fear of discrimination and embarrassment in front of the doctors, what led to the preference for community-based organizations, even if there were also some barriers identified with the CBO-based PrEP delivery, especially the distance and the difficulties to afford for transportation fees and other expenses related to this, long waiting times, and lack of confidentiality. Some high-class participants manifested their preference for private clinic-based delivery. At the time of the QualiPrep study, we had some key messages for the implementation of oral PrEP. And then, as I said, at the same time, the program was implemented in Cambodia. But the main key points were that there was low knowledge, but a very favorable context in Cambodia for the implementation of oral PrEP, the importance of CBO for supporting uptake, and then that there were very different case-specific preference for PrEP uptake and delivery models, and overall a good acceptability for injectable PrEP. The most important thing in terms of policy and trust, that was that the authorities were supporting PrEP, the involvement of key populations in the rollout, and this contributed to create the trust among key populations in PrEP. As you can see in this slide, there has been significant progress in the PrEP rollout in Cambodia, with 59 sites delivering PrEP, among them 25 community-based organizations, and more than 47,000 initiations of PrEP. This is oral PrEP and concern mostly MSM, transgender women, and female entertainment workers. We can see that other populations such as drug users and injecting drug users are not very represented in this PrEP rollout. In June 2025, long-acting PrEP has been implemented in Cambodia. It was the second country in the region, Asia and Pacific, to offer this long-acting PrEP. Up to the fourth quarter in 2025, there were more than 500 people on injectable PrEP. And as you can see in the graph, there is an important number of people that switched from oral PrEP to injectable PrEP. Long-acting injectable PrEP corresponds mostly to MSM, transgender women, female entertainment workers, and some people from the general population. However, some of the recommendations that we had at the time of the QualiPrep study persist in the era of PrEP and after the rollout of oral PrEP in Cambodia, and in the era of injectable PrEP. Those recommendations can be grouped in the need of improving the PrEP delivery system, especially enhancing hospital-based PrEP with stigma-free and adapted with opening hours and the preferences of key populations. The need of improving PrEP-related information specific to populations, for example, about the interaction with hormonal therapy among transgender women, but also targeting young people with specific activities such as HIV testing that may increase the demand on the use of PrEP. And improve communication by addressing social difficulties that can have messages reaching specific populations, especially those confronted to violence, alcohol or drug users, as well as the poverty problems. And finally, improving the efforts on hard-to-reach groups. One of them are street entertainment workers, transgender women, drug users, and especially chemsexers that are very difficult to reach in Cambodia, but also in other regions, in other countries in the region. At the time of the QualiPrep, we had some perspectives for future research, and one of that was the self-testing project, which is now ongoing in Cambodia in order to diversify the offer of PrEP and to reach other populations that were not able to go at that time to the ART sites or the PrEP sites and the CBO organizations. However, future research persists in the same area, especially understanding the profiles of people using injectable PrEP, who are those who switch from oral to injectable, who are those who prefer to stay in oral PrEP, who are those new coming to injectable PrEP that were not at the time of oral PrEP, but also understanding with more detail PrEP uptake, retention in follow-up, adherence to PrEP, HIV testing, and of course, trying to have an overview at a more representative level. It is important also to construct research that could help to explore other key populations, especially those that are hard to reach, such as chemsexers, for which we know very, very few things, and account for their specificities in terms of access to prevention for HIV. And of course, last and not least, the need of doing research in costing and health financing to inform the budget planning, the health security programs, especially in a context in which Cambodia is right now, which is the transition, the economic transition to a upper middle income country, and that we need this kind of research in order to understand behaviors, but also how we can make these PrEP programs sustainable once Cambodia will graduate as upper middle income country. I finished my presentation by acknowledging all the participants in the study, community-based organizations, the research teams, and a special thank you to my colleagues from the University of Health Sciences and the Nchats for the trust they had in me for doing this presentation. And of course, CANA, the CBO umbrella in Cambodia, and the support, financial, but also in the guidance from Anrs team. Thank you very much.
Thank you, Luis. So now we have finished with the presentations and we have some time for question and discussion on the 5 presentations you hear. Does anybody want to say something, to ask any question? Yeah.
Yes, I always have questions, but if other one has questions. So I have question for Andat. Who is he? He's here. He left. Okay, it's okay. So, but I have also a question for Professor Zhang. Very interesting data with my colleague Karine. We were wondering about the syphilis, because it's the first time we see a decrease of the syphilis among PrEP. So how do you explain that? Is it because you have high coverage in your community? And what also the rate of the other STIs? Because maybe I did not follow if they are increasing or decreasing. And the third question, do you have access to Mycoplasma genitalium testing?
So thank you for your question, focusing on STI issues among PrEP users in our clinic. I think it would be very cautious to sort of generalize what we documented from our own data, from our program data, to a more sort of representative level, right? So when you saw the syphilis number of cases going down, it may be because of the fact that all of the PrEP clients were able to receive syphilis testing for free, and that's also a sort of an intervention itself, right? So that's something that we have to be very cautious about. So we don't have the data at the population level. Right? Similarly, for the STI, all of the STI that we have data on MSM so far are clinic-based data. So it'd be very hard to extrapolate in terms of trend. We need to continue to work on it. But what we know is once the people are in service, in health service, there seems a good effects on the STIs, right? At least at the beginning when they are involved in attending the clinics. So what happened after 12 months, we don't know. What happened after 24 months, we don't know. And that's something I think is a empirical question that we need to answer. In terms of the Mycoplasma genitalium, we have also conducted a research on that topic, and I didn't present it here. And you could reach out to me or Dr. Paul Adamson over there. He would be able to provide a lot more details on that issue. But it's a major one of the issues that we are working on. Thank you.
Mark.
I have a question concerning the switch from oral to long-acting PrEP. In this population, do you test patients for HPV? And in those who are HPV negative, did you systematically propose vaccinations? Because when you are switching to long-term PrEP, there is no preventions for HPV. And for those who are already HPV antigen positive, did you propose prophylactic treatments against HPV by Hnkh? And that's for both of you.
That's also a very important issue, the HPV among MSM. Yes, we recently completed a study, a survey of HPV infections among our clients. I think that 500 in a sample of 500 clients in our clinic. I don't remember exactly the prevalence now. I could get back to you maybe later this afternoon. We also conducted the sequencings to detect the genotype of HPV. And I would provide that result to you later this afternoon. In terms of the vaccination, yes, I have a PhD student now engaging in a study that designing the how do I say, behavioral interventions, not just educational, but behavioral intervention to promote the HPV vaccine uptake among MSM who are attending PrEP clinics. And I think that's a very important area. The challenge is the cost of the HPV vaccine, right? So for example, in Vietnam now, if I remember correctly, about almost like $100 per dose, and they are still required to take at least 2. And that's quite costly for many of our clients. So that's something we have to work on, even if they are willing to engage in PrEP vaccines. So who's gonna pay for the cost? I think that's something we have to work on. Thank you.
Yeah. Thank you very much for very interesting presentation. All the 4 presentations are really, really fascinating. But I have a question regarding PrEP and seroconversion. So we work with CBO on PrEP. And one of the concerns of the CBO community-based organization is about seroconversion among the people who used to be on PrEP. Because they observe some phenomenon that people was on PrEP and then they drop out of PrEP, or they are like not adhere to PrEP very carefully, and then they seroconverted. So in the study that Professor Zhang presented, so seroconversion, the incidence is a bit more than 1 per 100 person year. My question is that, number one, I assume that for the program that run by HMU, by Hanoi Medical University, the quality of the program is good. So if for a good quality program, So seroconversion incident is 1 per 100 person year. What is acceptable seroconversion among the PrEP user? Do we accept one per 100 person year incident? And what about Cambodia? Oh, I mean, just like the question for everyone who can advise on PrEP, and how should we communicate with client and CBO about the seroconversion? Thank you.
Well, I can maybe give you some elements of thinking. When it was systematic condom use, when it was the gold standard, there were several seroconversion that were much more elevated than with PrEP. So no method is 100% perfect. The 100% does not exist. It's a myth. And of course, there are some, according to the PrEP molecules, the risk can be a bit higher, a bit lower. But you know, even with lenacapavir last year, people were saying it's 100% efficient. And now this year, we learned that there are rare, very rare seroconversions. So I think what for the CBO and for the people, for the clients, we have to explain that the null risk does not exist. There is always a very small risk. Even if you take a lift, you can crash. You take your car, you can have an accident. It happens. So it's part, you know, it's more the philosophy of risk that we have to deconstruct because no one will have a 100% method. Well, that's my opinion. I don't know if some colleagues want to add something, but
Yeah, I understand that there's nothing 100%. My question is more like, would that 1 per 100 person year incident is, is there any way we can do better than that? So just the question. So, I mean, maybe the answer is like, okay, that is it. That is the best we can get, just so that we can look at the quality of our program. When we do a PrEP program and we have a seroconversion of 1 per 100 person year, we would say, okay, we are not doing so bad. It's so just that small.
I have actually a question for the.
So sorry, no, I completely agree with Bruno on the comment. But if we are looking at the ending AIDS, right, the goal of ending AIDS, more than 1 per 100%, more than 1 per 100 person year is, we are still far from ending AIDS among MSM, right? So the challenge is just like going back, I would like to go back to Nicola's presentation this morning about TB, right? Biomedical intervention is not enough. Oral, injectable, whatever you have is not enough. You need social determinants interventions. You need interventions on the life issues of MSM. You need intervention on substance use. You need intervention on mental health. And you need other kind of interventions. It should be a comprehensive package. So that's what I'm trying to say, is that all biomedical intervention is not enough to lead us to the ending AIDS among MSM. Thank you.
I had a question here. Maybe also to the other speakers.
I have a question on antifungal infections, on invasive fungal infections in Vietnam. What kind of antifungal drugs are available in Vietnam? And are they accessible for the patients in terms of cost and availability?
But it's gone. I think the speaker is gone.
Maybe another clinician can answer.
Maybe a clinician can answer.
So Vũ Hải Vinh, clinician from Hải Phòng. Yes, for antiviral drug, we have in Vietnam the amphotericin B and liposomal. We have also the family of azole, like itraconazole, fluconazole. We don't have sulcitozine and the other. And it is all available in the big hospital, like a provincial hospital or hospital in Hanoi. And it is coverage also by health insurance. So it is accessible. Thank you. The cost, liposomal amphotericin B is a bit expensive. Amphotericin B and azone is cheap because we use as a generical produce. Yeah. Thank you.
Okay. I have a question to Dr. Nguyen. Yes, Dr. Tai, sorry. About you show your 3 pillars in your presentation. That was very interesting. But I was interested by the 3rd pillar. But do you think we have real data on how people live with these new drugs in terms of quality of life or any patient-reported outcomes? Because it's always a theory. All the new drug companies said will be better quality of life, but actually they never present any data. They just show the medical usual data, but no data on how the patients experiment these new molecules in reality. So can you comment on this?
Yeah, thank you very much for your questions. As you may know that the psychological aspects are very important for HIV patients. So far, we consider this aspect as one. Well, I think that one important thing need to be addressed. So the pain burdens and also the dosing is affected so much about almost the patients they feel not so comfortable for day by day getting the drugs and month by month going to the OPC to refill the medications. My idea that in future, not so future, in near future, because now I'm running the project to assess the quality of life and also the how to say neurocognitive impairment of the patient based on the some tools, for example, the root pegboard to clarify whether or not the patient need to be approached a better regimen for the ARV treatment. And also about the needs for a better regimen. So many people, so many patients with HIV, they ask for the newer regimen, better regimen, and even they pay much more for that kind of regimen. They still be happy to continue. The big problem that in Vietnam so far, the availability of the new regimens are very limited. Yeah, that's a big problem. So we just to do research on the needs, the current situation and the needs, but not the comparison between the newer, the older regimens. And I think that in future, I hope that we can run the research into Vietnamese population to get because sometimes the culture aspect affect a little bit to the psychological aspect. So I still then want to have the real data from the Vietnam to know much more about whether or not the new approach to improve the psychological aspect of the patients. Thank you.
I just want to add something, Dr. Tai. In France, we have access to injectables, drugs. So that means that we can inform our patients and they can choose what they want. And you have to know that it's not like WHO say, injectable will solve all the problem. In our country, the treatment is available since few years, 3, 4, 5 years, I don't remember. And it's around 10% of the patient who wants to switch to injectable. If we ask them, because we have to ask them, they receive a treatment with effective 1 pill per day. And then we have a new way to take the drug, so injectable every 2 months. But the majority, the high majority of people who are on treatment control, they don't want to switch to injectables. So what Bruno says is very important. Maybe with 6 months it will change, but maybe not. We don't know what people want, in fact, if we don't ask them. So it's good to have molecules, but it's not enough. It's for patients, so we have to ask them, I think.
Yeah, the problem that the balance between the cost, the availability, and also some other aspects related to the living activities. So yeah, I agree with you that truly the needs that's maybe estimated over or less. Thank you.
There was a question around here. I saw a hand. No? Yeah. Okay.
Hello everyone, my name is Ling from VADP MO8. So thanks for your question. So I would like to provide more information related to the quality of life for people living with AIDS and key population in Vietnam. As you may know that in Vietnam, so we are implementing the national strategy to ending AIDS to 2030. So in the last year, so we have the midterm review to implement of the national target, national strategy, and the quality of life index is one of limited in the data we need to review in the midterm review. Therefore, in the last year, so from since the last year up to now, so we have collaboration with the CDC US to pilot evaluation quality of life in some very small clinic, because you may know that US CDC PEPFAR just cut down of funding for Vietnam a lot. Therefore, so we can pilot and implement in the small clinic. And the second thing, in Vietnam, so we in the national strategy in Vietnam, so we have implement 95 target. So and now so we are planning to develop the core indicators to measure for the 490 related to the quality of life and improve quality of life and reduce stigma and discrimination in Vietnam. Thank you.
Thank you. So you?
My question is for Dr. Luis. Was wondering, based on the results of your study, how do you would you recommend counseling patients about condom use when they're on PrEP? Do you suggest that they use condoms, or how would you think patients will respond to that?
Thank you. I think the answer is not very different of what is done in France or in other countries, is that recommendation of condom has to be systematic with PrEP. So this is the way in which PrEP sites are doing in Cambodia, either public sector or CBOs, is systematic recommendation of PrEP. Then there's the perceptions and the beliefs. So that's why it's important, this kind of research, because key population were thinking that PrEP was mostly to avoid using condoms. But the messages are the same as we do in many, many countries.
Okay. Are there any other questions? Okay, so thank you. I would like to thank all the panelists and all the people who asked questions for this interesting discussion. And so we are going to lunch, and I think we have to come back at 1:30. Bon appétit.